questions which all of us will get few questions which are relevant. But
Good morning, respected faculty.
if you present like MCH, that will make it quicker. Please go ahead.
My name is Dr. Ridhima. I'm a second year PG resident from AM Rishikesh, and I will be presenting a case of post-mortem contraction of the axilla. So my patient is a 16-year-old female who is a resident of Peshawar from Uttar Pradesh. She currently has no occupation and lives in household work, and she complains of inability to lift the right arm since 6 years. So the patient came with history of thermal burns due to fall off lamp 7 years back, after which she sustained injury over the lower face, neck, chest and right upper limb. She was managed conservatively at local hospital with regular dressings, and the duration of hospital stay is not. 4 months after the discharge, she developed tightness over the right arm and axilla and had difficulty in lifting the arm. She complains of inability to do overhead abduction and reaching objects overhead and combing hair. There is no history of any physiotherapy, no history of splintage or any specific positioning, no history of any pressure garment application. There is also no history of any ulceration, irritation, reddening of scars, no history of any surgical procedure, no history of inhalational injury, and no history of any other comorbidity. Coming to the general examination, patient was examined in a well-lit room after taking proper consent. Patient is conscious and oriented to time, place and person. She is moderately built and nourished. Vital signs are stable, and there is no pallor, icterus, cyanosis, lymphadenopathy or edema. On general examination, we can see healed post-burn scars over the neck, chest, right axilla and arm. So the patient was examined in standing position with arms by the side and arms abducted. Coming to the inspection, anteriorly we can see the scar which is extending from the left chest at the level of the mid-clavicular line across the anterior axillary fold onto the right arm. This was the horizontal extent, and vertically you can see the scar extending from the acromion till 10 cm below the acromion at the level of the axilla. The contracture band is also seen at of around 4 cm width in the lower part of the scar previously mentioned. Posteriorly, vertical extent of the scar is from the acromion to 10 cm below the acromion, and horizontally it is extending from the lateral border of the scapula till the right arm posterior aspect till the elbow. A contracture band is also seen in the posterior axillary fold onto the right arm. The skin surrounding the contracture band, there are areas of hypopigmentation, depigmentation and hyperpigmentation. The axillary dome appears normal with axillary hair, and there are no erythema or ulcers. On palpation, inspectory findings are confirmed. There is no local rise of temperature, no tenderness, no blanching. Scar is supple and smooth. Coming to the range of motion, the abduction is restricted to 60 degrees. Adduction, there is no restriction. It is within normal limits. Flexion, extension, both are restricted, and internal and external rotation are also restricted. Coming to the examination of donor side, bilateral thighs are free of any scar, and the back, the scapular region is also free. Coming to the systemic examination is within normal limits for all the other systems. So my diagnosis is post-burn contracture of the right axilla involving the anterior and the posterior axillary fold, which is class 2, Kurzban and Stern.
What is classification? Class 1, class 2, class 3.
So class 1 is involvement of either anterior or posterior axillary folds. 1A is involvement of anterior axillary fold and 1B is posterior axillary fold. Class 2 is involvement of both the folds, and class 3 is involvement of the axillary dome or the cupula.
As well.
Yes.
As
3
well.
is should I proceed further? So
You said flexion and extension of.
at the shoulder joints.
Can you show me which movement is flexion of shoulder joint? Stand in front. Not enough. Show me abduction. The quote is probably.
Flexion is this way.
Flexion is this way. And extension is correct. Very nice. And circumflexion. That's it. Okay.
Should I proceed?
Yeah, please go ahead.
Okay, so coming to the management, I would first like to investigate the patient with routine investigations for the anesthetic fitness and also get since the shoulder has been immobilized for a long time and to know if there is any bony movement, which is rare in cases of contractile due to the skin and subcutaneous tissue involvement and the shoulder is immobilized, but in case of rare circumstances, there is another possibility of joint involvement. So I would like to do that now.
Joint involvement you anticipate for which you will take. You tell because you want to see what?
Yes. So it is a very rare complication in burns, which is heterotopic ossification, where around the ligament there can be deposition of bone, and the symptoms would be pain and stiffness of shoulder joint. No, I don't have the X-ray, but
your clinical findings are not suggested.
yes, yes, ma'am. But
Which joint normally is likely to undergo heterotopic ossification if immobilized for a long time?
elbows.
Which muscle will get the ossification? There are only two muscles in the flexor compartment.
Name those two muscles. That's it. Good I asked. Now they are not two muscles.
Brachialis.
He said only two muscles.
Biceps.
Yes. Brachialis and biceps.
So actually why I asked about X-ray is because for the sake of investigation don't do anything. We normally don't do axilla for shoulder contracture if there is a mobility because a 60-degree abduction is possible.
Yes.
And she is performing all her activities, so it is less likely to have unless some symptoms are there.
You do it routinely in your session? No.
तो फिर मैं बोलूँ
Completion.
Completion. No. Is it really completion or are we over investigating? Like we should depend to some extent on our clinical findings. And if you have a doubt, go ahead.
Okay.
So coming to the treatment, my first plan for this patient would be contactual release and closure of the wound with the split thickness skin graft. The second plan would be release of contracture.
Just stick to one.
So it is skin grafting and release and skin grafting.
Oh,
my plan.
yes.
So we can give a single incision at the point of maximum tension or contraction and give fishtailing at both the ends. This is for both the anterior and the posterior axillary fold. And the other option that we have is a bipedical release.
No option. This is one patient you will operate only once. So make
Now you
one
are
incision.
operating, not suggesting.
Now, when you plan this, have you seen the surrounding skin on both the sides? Will you be doing the same procedure on both the anterior and posterior folds?
Yes, ma'am.
Do you think that you have seen axilla contracture in this?
Yes, sir.
Huh? Do you think that fishtail and this length only on skin surface will release the contracture?
So I might have to extend the incision.
Why don't you extend the line there? This triangle will not serve any purpose.
Yes, sir. We have to extend
You can extend what?
the fishtails.
The length of these two limbs
Yes.
that is to be extended, or this line, red line, this straight line needs to go a little up and then fishtailing needs to be done?
Both of them.
Both of them. Okay.
How far deep you will go and what will happen to the apex of the axilla? What you will do with the axillary hair and apex of the axilla? You have got contraction on two sides. Middle skin is normal. Hair bearing skin is there. What will you do to that area? Will your incision go through that or you will do something
So
else?
we would like to preserve it as much as possible. We don't want change in the position of the cupula and the hair veneer. So we would prefer the scar more towards the scar side and the angle actually.
To preserve the cupula, is there any other way in which you can plan your incisions? Where you don't have to go anywhere near it?
So for the same grafting procedure or any other?
We're talking just about the release at this point, and it's followed with a graft. But is there, so in an area where you want to preserve it at the depth, the same thing in the perineum, you might consider this. Any other, one was aware of any other way of releasing, any other incision?
Along the contracture band.
Sorry? Bipedical release. Have you heard of
That was another.
So the second
No,
option
no,
is-
so you've got, so the question, you don't need one option like we said. So the point is that you're trying to preserve the, so you should, okay, but again, your release
Yeah,
is
small,
completely inadequate.
Also, into
And
the cupula, you don't want to put those two fishtails going right in and spoiling the cupula.
It will be better to make this as a V and extend outward, so that you push that V into the.
invariably when you have got type 2, release is almost like type 3. May not be through the scar, but you have to go around below the apex or cupula and then preserve the hair bearing skin in the center, in the place. And then you might need to put a graft or local flap or something like that above and below. So your one line incision cannot release the contracture. What are the structures which are likely you would like to preserve in this, or you are likely to damage if you are not careful in this place?
In case we go to deeps, then we can go towards the neurovascular axillary artery vein.
Especially in type 3, and if you have got deep scar, you might have, you might reach very close to your axillary artery and this secret plexus. So you should be careful.
So let us say that you have got your full release. And now how do you immobilize the patient?
Immobilize, ma'am, after the surgery, we would like to
Immobilize the graft you are.
patient,
Joint.
put the help
she's
in
done the grafting.
You finish
Put
the
them
graft,
down.
you have given a dressing.
over the dressing.
Yes, yes, plenty is position.
So the degree in which the splint would be abducted would be 90 to 120 degree with a flexion.
No, it is in your hand. Are you going to say, okay, like this, give it between 90 to 120? What will you do?
Around
You've
120
got a-
degrees
you've got a
of
full
abduction and 20-degree flexion at shoulder joint.
No, no, start again.
120 degrees of abduction and 20 degrees of flexion.
What is flexion?
She means in front, rather than behind, she will
It
make
is a
it
little
in
in
front.
front because this position has been shown to put less stress on the brachial plexus and also provide more stability to the green of the shoulder joint. A little
So I'm not happy with 120. Generally don't cross 190. Your number, anything beyond 110, it may cause stretching of the
Brachial plexus, 100 lines.
100.
flexion या extension में जाओगे तो there's a little bit of worry about, one side is going to contract with you, one side is going to contract.
This is printed,
You have
got some needs such as.
airplanes. Airplanes.
Aeroplane split. Wings of the aeroplane. Alright, aeroplane with
I
one wing.
have pictures.
Yeah, aeroplane with one wing only. That's okay. That's okay. So on table, how do you assess? Did you worry there when PBC neck was discussed? So on table, how do you assess? You don't have to achieve up to 100 degree on table.
So,
On table you have to achieve
180 and above.
splintage is in 100 degree.
Yes.
You can't splint it like this.
Yes.
Splintage is up to 100 degree. On table you must check whether the knees are in.
Yes, we try to reach the hand towards the opposite ear to see if the patient can perform overhead abduction.
Use the arm by the side to like that. Because if the child,
Arm should be touched.
yeah, if the child or the boy or girl things like this, guiding.
When you do the release, your endpoint when you release, what is the angle you expect to achieve?
The arm should touch the ear and the patient should be able to perform overhead
So
abduction.
what care you will take while positioning the arm when you are at that overhead under the knee? What rotation you will like to have of the humerus? What is the position we want to have a safe abduction? Anybody? If you rotate the humerus in abnormal position, you might cause brachial pulse. It doesn't happen very often, but it can happen. So it should be medially rotated and then abduct. Because the head of humerus will go inside the socket. If you externally rotate and then abduct, the head of humerus comes out and you cannot abduct fully. This is the maximum abduction you can do. It is only 120 degree or 130 degree. You should be careful. Then madam is asking about these 3 weeks.
Exactly. How do I know? 3 weeks.
This is not the exact answer for this, but if the duration of splintage changes, if we are going for a flap or a graft, if we are going for a graft, we would like to
What are you doing?
for
What are you doing?
grafting.
इस केस में ग्राफ्ट किया ना?
Right, तो आप क्या देंगे?
So at least for 6 weeks, I would like to go for splintage followed by only night splinting for another 6 months, like a total of 6 months.
Should be very worried about the recontraction, right? At 6 weeks or 3 weeks, you give up the splint. Graft है ना, it takes time to stabilize and it will recontract. So my personal feeling would be night splint after 6 weeks. After 6 months, I would like the patient to wear it maximum. But because it is an axilla, after 6 weeks, we wouldn't mind take it out. We want to do some special work, but we send it back into that splint because it will surely want to contract again.
What else do you do in post-op? What else do you advise in post-op besides doing this split?
Yes. And to prevent any hypertrophy, and also
Anything to be applied?
silicone gel sheets.
To the graft?
Will the silicone gel sheet stick to the axilla? Have you used silicone gel sheet in axilla?
We put silicone gel tube.
That's a place where it won't stay.
Have you heard this term scar massage, graft massage, lubrication, physiotherapy, cementing massage, exercises? All these things need to be stressed upon. Otherwise, patients they come back saying, all this. Okay?
Your another option was Z plastic photos. Can you put Z plastic photos?
She had in the
Our second choice was Z plastic.
Can I see the pictures? You
Third plan was jet plastic.
Local flap Z plastic. You think this will help?
This
Have
would
you
not
seen
lead to complete release in my opinion, and since the skin is scarred, there is possibility of
Then
laminate
don't
growth.
mention it
Then
at
what
all.
should you mention?
Then don't mention it at all. That is
You may
not
cut
an
like Z,
option.
but you will end up putting that if you want to achieve these.
And afterwards, you have to keep your grafted skin soft and supple by application of some moisturizer or even coconut oil or anything. Good massage, good physiotherapy.
Any role of subcutaneous propeller plan?
Yes. Like we.
That's also option there.
Yes.
The options. See, You will be happy to see this as the first option if you put it. Then you will also put this as the first option.
Yeah, this is good.
So actually, we have never performed this in our center, so I'm not comfortable with it, so it is not my first choice.
This is a good answer.
Justified.
This is justified. But there is no center on this planet which can claim that we perform all surgeries. Plastic surgery has widened so much in its horizon, it is just not possible for any center. Head to toe plastic surgery, no point.